Thank you very much, and thank you for the privilege to talk to you about imaging the aorta and vascular tree. So these are my disclosures. So I was asked to speak about measurement techniques and standardization, Z-scores and indexed areas, and what to image, which modality, and how often. So when we see patients with aortic disease, a lot of what we do relies on the diameter, including the seminal data about the risk of dissection in Marfan syndrome that is essentially based on the size of the aorta. Surgical indications for aortic aneurysms are also based on diameters, and 1 millimeter can make the difference between surgical and non-surgical. At least it's the way. It may not be the way we do in practice, but it's certainly the message that's going around at which diameter to get worried. And these diameters vary with indication, with genotype, with family history, with change over time. So imaging, although it is never as powerful as a clinical examination, is at the center of what we do. So the first thing about imaging is actually not to measure the aorta, but actually to look at the shape of the aorta. So a normal aorta has a sinotubular junction. The classic dilatation of the aorta in Marfan syndrome is the pear-shaped aorta that involves the root. It can be more severe and you can lose the sinotubular junction, and we'll see a little bit of data that shows that this may carry a worse prognosis. And then there's also the ascending aorta dilatation, which is commonly associated with the bicuspid aortic valve or with hypertension or with degenerative atherosclerotic disease. So it's actually important just to look at what the aorta looks like. Why is this sinotubular junction important? This is a small series that shows that Marfan patients who actually lose their sinotubular junction have a higher risk of aortic complications. So echocardiography is usually at the center of aortic imaging. So these are the standard views to measure the aorta and parasternal long axis with the LVOT, the aortic valve, and the aortic root, which is severely enlarged in this case. The measurements, as we'll see, are usually taken from leading edge to leading edge. However, if you're doing transthoracic echocardiography, do not forget about using the right parasternal view to see the ascending aorta, which can give a better image than the standard parasternal long axis view. It's also important, both in echo and in axial imaging, so CT, angio, and MRI, to measure the aorta at consistent landmarks and to report them serially. These landmarks are particularly important when we're talking about the aortic root. So the aortic root actually has 4 parts: the annulus, the sinuses of Valsalva, the sinotubular junction, and the ascending aorta. And then there is controversy about how to measure it. Echocardiography normally measures the aorta from leading edge to leading edge. That's a measurement technique that's still used but inherited from M-mode imaging, which we're not using anymore. And there's also been a trend during the last 10 years or so to use the inner edge to inner edge diameter. But that can make a difference in the measurements, although the most recent echo guidelines have gone back to the leading edge to leading edge. The way you measure the aorta will also change depending if you are a pediatrician or an adult cardiologist, because pediatric guidelines will tell you that the aorta should be measured in systole, technically when the diameter is the largest, but adult echo guidelines are consistently recommend that the aorta is imaged from leading edge to leading edge in diastole, because diastole is thought to be more reproducible. So there could be a change in diameter just from measurement technique when patients transition from pediatrics to adult medicine. Axial imaging, such as CMR, more and more is moving toward imaging the aorta with double oblique imaging. So this is an example of the aortic root where you plan a short axis of the valve from 2 long axis views, and the planes should be perpendicular to the aorta in both planes. But then again, there are 2 classical ways of measuring the aorta, where you can go from the cusp to the commissure, or from the cusp to the cusp. And these give slightly different diameters, and we'll see a little bit more comparative data between echo and CMR and CT. The other main point about imaging the aorta is to use multiplanar reconstruction of a three-dimensional data set. So here you see an example, as you've just seen before, of the ascending aorta that's been reconstructed from two perpendicular views to produce a true short axis of the ascending aorta. Why is that important? It's because if you cut the aorta axially, like in this case, you can get a ellipse-shaped aorta instead of a round one. If your surgical threshold is at 50 millimeter, which is a common threshold, then by just changing the measurement technique, this same patient has just gone from surgical to close observation. So it makes a major difference. I wish that the guidelines would be standardized. However, there are at least 4 scientific organizations that produced guidelines on how to image the aorta, and there is still controversy about whether the edge of the aorta should be included or not included. But if you think about it, it really depends on how you measure. If you measure on an angiogram, what you see is actually a luminogram. You see the lumen that is filled with contrast. Therefore, it's inner edge to inner edge that you're measuring. If you use imaging that includes the wall or that allows you to see the wall, then you may decide to include the wall or not. The timing in the cardiac cycle is another issue, which I've explained with echo. Usually in adult medicine, it's pretty consistent that, that the aorta is measured in diastole, but I've told you about the pediatric way of doing things. And then which diameter should be measured. I see too often colleagues who see a patient, the patient has had a CT angio or an MRI, they open the packs, they see an axial imaging of the ascending aorta, they draw a line and they take a measurement. That's not a 3D reconstruction, and then you cannot be sure that you're measuring a true short axis of the vessel, therefore you may overestimate the aorta. So a few key points about how to measure the aorta. So it should be done on ECG-gated images, which is usually not the case of the regular CT scan. They should be perpendicular to the axis of blood flow. They should use multiplanar reconstruction. They should be done at reliable and reproducible anatomical landmarks at the largest diameter. There is, sadly, no consensus on wall inclusion, whether you use inner edge to inner edge or leading edge to leading edge. There's no consensus on how to measure the sinuses of Valsalva, but the method of measurement should be documented in the report, and you can even save screenshots of key measurements to make sure that the next imager will know what's been measured. Serial imaging should be done, if possible, with the same modality that best demonstrate the aortic segment of interest. A significant change, which is usually 5 millimeters by echo, 3 millimeters by CMR or CT, should be confirmed with additional imaging, especially if you're close to the surgical threshold. And then the measurement should account for age, sex, body surface area, and the phase of cardiac cycle. We usually think that diastole is more reproducible over time. So my first take-home message is be critical of how measurements are made, remembering that they are by no way standardized. The aortic size also depends on body size. So there are numerous fairly large studies that have shown that 40 millimeters is dilated, except in some individuals who have a fairly big body size. And there are similar data for 2D TEE, both in the both in the aortic root and in the ascending aorta. There is also a similar set of data for CMR, and then if you draw a line at 40 millimeters, if that's your kind of go-to diameter, that you're very unlikely to miss severe dilatation, but you may miss patients who are actually large for their body size. The key example of the importance to adapt aortic measurement to body size is actually Turner syndrome. I don't need to tell this audience what Turner syndrome is, but I will remind you that 16% of them have aortic dilatation. That aortic dilatation is usually defined as larger than 2 centimeters per meter square, and that these patients usually get their dissections at diameters that would be considered normal or near normal in a larger individual. So what do we do for imaging for Turner syndrome? We usually do echo and CMR or CT at diagnosis. Then if the aorta is larger than 35 millimeter, or more importantly, 25 millimeter per meter square, these patients should be referred for, or at least considered for elective surgery. If the diameter is less than 20 millimeters, they can be seen back in 5 years with imaging. But if the diameter is between 20 and 25, if there is a bicuspid aortic valve, coarctation, or hypertension, imaging follow-up should be done closer in time. So another take-home message, normal aortic size depends on body size, and beware of Turner syndrome. Now, there is this large series published in 2016 that has shown that in patients with hereditary aortopathies who had a dissection, only 13% of them had their dissection at a diameter that would be considered a surgical threshold. Therefore, enlargement, or at least diameter, does not contain the full information. So there was, before the break, a little bit of discussion about Z-scores. So Z-scores, there are at least 3 equations to calculate them. In this study, they took 260 Marfan patients, more than 2,000 echoes. They measured the aorta in standard ways by echocardiography. And they've concluded that they've looked at which Z-score was less likely to miss an aorta of more than 40 millimeters. So to adequately classify an aorta of more than 40 millimeters as dilated. And they found that the third equation that they were using was actually the best one. This equation, which they call Z3, corrects for heights. It's not affected by age or body weight. And it does anticipate that any aortic diameter above 40 is abnormal, so there's no linear assumption. So number one, about Z-score, the equation is important. These other researchers have looked at how do Z-score perform depending on different body weights, and they have shown, as we've all experienced in clinic, that aortic dilatation will be missed in overweights and overdiagnosed in underweights using Z-scores. So therefore, to identify the patient at risk of dissection, we have to remember that small size individuals, we cannot rely on absolute diameters. That diameter seems to miss some patients at risk, but that Z-scores are far from perfect. They are derived from echocardiography diameters. These are not double oblique images. They therefore do not account for eccentric dilatation, and that they rely on BSA, which is always affected by obesity. Therefore, there's been a regain of interest into the indexed aortic area to identify patients with aortic dilatation that may be missed by aortic diameter. So in this study, indexed aortic area, defined as more than 10 centimeters square per meter, identified a subset of patients with a bicuspid aortic valve who did not meet surgical indication, but who did carry a higher risk of aortic events if not operated. And an aortic diameter greater than 5 centimeters in that series did not predict death as well as the indexed aortic area. So similarly, in this later series, 69.5% of patients with an indexed area of more than 10 centimeters square per meter had a diameter below the surgical threshold. Notably, almost half the patients with an aortic diameter between 45 and 50 millimeters. So the indexed aortic area may be a more refined marker of risk in patients. A major critique of that study, however, is that they did not actually draw the aortic area. They calculated it using the formula from the area of a circle. But that, of course, does not apply to the aortic root, which has petals. So again, another comment about normal aortic size and body size is that Z-score may be misleading in extremes of weights, and that the indexed aortic area is an interesting marker of aortic dilatation. As far as imaging modality goes, they all have their pros and cons. Echocardiography is non-invasive, it's simple to do, it's available, and it's fairly cheap. However, it has some limitation, notably operator dependency. CMR and CT scan offer comprehensive evaluation of the aorta, although CMR may be less available and also carries some operator dependency, maybe less than CTA, which is probably, except for the fact that it exposes to radiation, a very good way of imaging the aorta. It's certainly the imaging of choice in the case of an acute aortic syndrome. CMR, however, offers a comprehensive evaluation that not only includes aortic size, but allows to study heart function, heart size, and also to quantify aortic regurgitation. So this is an example in a patient with Marfan syndrome. Oops, sorry. Sorry, something wrong. We'll get that back. Here we go. So this is an example of what comprehensive aortic imaging by CMR will produce. So you have longitudinal views of the aortic valve and the aortic root. You see that the aortic valve is tricuspid, that there is substantial regurgitation, and you get a nice 3D reconstruction of the aorta showing the classical pear-shaped aortic root. CMR also offers the possibility to do an aortic angiogram without using contrast, which is desirable for follow-up of younger patients. It uses a CMR technique that is called beta SSFP, but this is sensitive to artifacts. However, in one study, there was no difference in diagnostic accuracy for aortic dissection between non-contrast and contrast-enhanced MRA. And the advantage is that if you use contrast-enhanced MRA, you may get blurring because the aorta lumen is very bright due to the contrast. And even if you window it to try to make the aorta contour more conspicuous, it is still not as good as the image that you actually get without using contrast. So this is easier to place the boundaries on where to measure. CTA, as I said, is the imaging of choice for an acute aortic syndrome. So here you see an example of dissection with what's called a central line reconstruction that basically takes the aorta, strengthens it out, and allows measurement at different levels. Radiation is always a concern with CTA. However, with newer CT scans, notably dual source CT scans, which use two X-ray tubes which are offset by 90 degrees, it is possible to produce a complete aortic angiogram with a low volume of contrast and a low dose of radiation that mostly relies to triggering the imaging to diastole when the aorta is not moving, and most of the information can be acquired. So how does echo compare with CMR? So TTE diameters in one study were actually smaller than CMR diameters, but they were both reproducible for measurements of the aortic root, but CMR more than transthoracic echo. Transthoracic echo is not surprisingly less reproducible for the ascending aorta, but CMR was highly reproducible with the advantage of measuring cross-sectional diameter. How does echo compare with CT scan or CTA? So cusp to cusp CTA diameter are more comparable to TEE, and cusp to commissure give smaller diameters than TTE. So if you want to compare the results of an echo with a CT scan, you should use a cusp to cusp diameter on the CT scan. But as the aortic root has 3 petals, there is no anatomical marker to make sure that the transthoracic echo is actually measuring the same diameter as the CT scan. And it's actually not known what diameter will be predictive of outcome. So how do we judiciously use CMR and CT? So they should be done at diagnosis and at infrequent intervals thereafter. I think the imagers should consider reporting both cusp to cusp and cusp to commissure diameters for more informed comparison with the routine transthoracic echo imaging. And that axial imaging should be more frequent if the echo windows are poor, if the diameters are close to surgical threshold, if there's significant asymmetry, or if there is dilatation of the descending aorta, which cannot be seen on echo. CTA and MRA are also a key part of postoperative imaging. So another take-home message is that the non-contrast MRA or low-dose CTA may be the preferred imaging for aorta measurement. So now if I go a little bit more disease-specific, I won't dwell on what Marfan syndrome manifests, on the manifestations of Marfan syndrome, only to show you this imaging data that compares bicuspid aortic valves and Marfan syndrome, showing that they actually have the same rate of aortic enlargement. It's just that aortic enlargement is more common over time in patients with Marfan syndrome. This is an example of the imaging algorithm that I use for imaging Marfan syndrome. So they usually get an echo and CMR or CTA at diagnosis that should be repeated in 6 months to ensure that there's no progression. If there's no progression, so 1 millimeter per year of aortic size change, annual imaging could be done, annual TEE with CMR or CTA spaced out every 2 to 3 years. If there is progression, it should be confirmed with CMR or CT if there is progression on echo. And then if the progression is mild, so 1.2 to 5 millimeters per year, we could consider closer follow-up. But if the progression is more than 5 millimeters per year, that's considered an aortic surgery indication. And I've listed up here the standard indications that you know for aortic surgery. We may learn more about how to tailor follow-up based on FBN1 genotype. It's been shown that patients who have aplo insufficiency in the FBN1 mutation, that the FBN1 mutation that cause aplo insufficiency are associated with larger aortic root at baseline and faster growth, so they maybe should get closer imaging follow-up. There is also 4D flow MRI that is becoming more and more available. So interestingly, this study has shown that there is abnormal flow in the proximal descending aorta, which is a critical site for dissection, which was absent in normal patients in that study. Aortic stiffness, I know there's going to be another talk about that later on. Surprisingly, in this study from Boston, the rate of increase in stiffness was not different between connective tissue disease patients and normal subjects. So I'm not exactly sure yet if that's ready for clinical practice. So another key point is to confirm progression of aortic size with axial imaging. The aortic valve can have a lot of anatomical variations. So you see the main 4s here. The most common that we see in terms of abnormal aortic valve is the bicuspid aortic valve, and as it has been suggested before, the bicuspid aortic valve is kind of a strange animal that can lie at the intersection between isolated bicuspid aortic valve, aortic disease, and family history. It's also seen in up to 30% of patients with Turner syndrome, about 20% of patients with Loeys-Dietz syndrome, 10 to 15% of patients with ACTA2 mutations. So if you see a bicuspid aortic valve, it's certainly worth looking for any suspicion of these conditions. The follow-up, the imaging follow-up for bicuspid aortic valve starts with TE, transthoracic echo and CMR or CT at least once. And it goes the same way as for Marfan syndrome. If there are indications right away, the patient should be referred for surgery. Otherwise, he should get follow-up imaging. Okay. Similarly, for Loeys-Dietz syndrome, I will skip the clinical manifestations. So this is the imaging follow-up for patients with Loeys-Dietz syndrome. The baseline imaging is a little bit more detailed. It includes echo, MRI from head to or CT from head to pelvis. cervical X-ray, and genetic testing. The imaging should be repeated in 6 months. And then if it's normal, I tend to space it out every 1.5 to 3 years instead of the very rigorous annual follow-up, because it tends to be cumbersome for patients to have repeatedly normal imaging. One word about ACTA2 mutations is that when they get their head-to-toe imaging, attention should be put to the brain imaging, because there are some studies that indicate distinctive features on brain MRIs, which I won't dwell on. And this is the imaging tree for patients with familial thoracic aortic aneurysm and dissections, which is fairly similar to what we do for Loeys-Dietz syndrome. And also for Ehlers-Danlos. So all these will be in the handouts for future reference. And I will, in the interest of time, I will just summarize with a few key points. So aortic imaging guidelines are not standardized. At the very least, there should be standardization at each center. And I urge you to be critical of how aortic measurements are made. Normal aortic size depends on body size, so beware of Turner syndrome. Z-score may be misleading in extremes of weight. Indexed aortic area may be a better, may better identify aortic dilatation than diameter alone. Consider non-contrast MRA and low-dose CT angiogram for serial imaging. Always confirm progression of aortic size with CMR or CTA, and be sure to image from head to pelvis, particularly in non-Marfan aortopathies. So we have summarized I have summarized the discussion previously in a review paper in 2016, and I want to thank all my colleagues at the Aorta and Connective Tissue Clinics in Montreal, both at Saint-Justin and at the Montreal Heart Institute. So if you ever have patients that move to Montreal, give us a call.
Thank you, François-Pierre, for this. Thanks, François-Pierre, for this very comprehensive review. Perhaps we'll take 1 or 2 questions from the audience in the interest of time, and then we'll open the discussion to the whole panel at the end of the session. So, are there any pressing questions, please?
Thank you very much. Are there any references for the aortic arch measurement?
You mean normal references? Not as comprehensive as the ones that you have for the ascending aorta and the root. However, if you, in the European guidelines, there's a graphic where they give normal ranges that can be used. In practice, usually we use 30 in adults. If it's larger than 30, then it's dilated.
Sorry to hog the microphone, and apologies in advance for my terrible French, but très formidable. It was a very wonderful talk. I just one comment, just from an echo point of view. You mentioned using the parasternal, the right parasternal. We found that in the Marfan trial, that actually using the first left parasternal space was actually more reproducible for the ascending aorta, because you can use the right pulmonary artery as an anatomical landmarker and always measure it at the same time. And I found that that's a very useful sort of clinical pearl. One other thing from the right parasternal view is that it seems when we compare that to MRI, that in the standard left parasternal we measure from non to right, or right to non actually, and then in the right parasternal we measure from right to left, and so they seem to equate better to those sort of MRI views. The question was that when my experience at Toronto General was that when the people did MRIs, that they would measure the 9 measurements of cusp to cusp, cusp to commissure, commissure to commissure, and then they would go back and repeat the measurements for standardization against. And so then you get the variability of 18 different sort of measurements compared with our single measurement on echo. So it always brought up a clinical dilemma: which do we use, and is the MRI or the CT more accurate, because now you've got the variability of 18 different sort of measurements, and so it's how do we use that in a clinical sort of setting. I mean, as you pointed out, it seems that they usually measure 2 millimeters more, and so we always tend to use the largest measurement as far as surgical indication. But is that how you do it in your clinic as well?
So I think you've summarized absolutely the dilemma, and there's no answer. The only thing I consider is that if I will not refer a patient for surgery if I have only one diameter that is at the 45 or the 50 millimeter. It has to be somewhat consistent, that any way I measure it, I get at the surgical threshold, because especially with the MRI axial measurements, because sometimes you have enlargement of one sinus that will make this measurement particularly large, and the rest of the root is okay. So isolated sinus of Valsalva dilatation, I follow a fair number of patients like that. They usually don't change, and I can't see that as an indication for surgery. So I try to summarize and to get and to send patients for surgery if they have multiple measurements consistently at the threshold. However, I never average them, as is done sometimes in clinical trials.
Okay, thank you, François-Pierre. This was really fantastic.